Good evening, everyone. I'm Andrew Penn. I'm one of the co-founders of Open Nurses, and welcome to our monthly psychedelic chat. This month, we are joined by one of our colleagues from Canada. Bryce Koch is a queer, non-binary nurse practitioner with a spread of experiences ranging from emergency medicine, public health, substance use management, and mass gathering event management. He is currently the day health nurse practitioner for the Dr. Peter Center in Vancouver, Canada, where he provides support for people who use substances, including psychedelic support. He also has a private practice where he provides medical consulting services for registered and non-registered providers who want to use psychedelics to treat their clients. He's also one of the charge nurses for the Shambhala Music Festival, which is Canada's largest psychedelic harm reduction music focused festival. So as I add Bryce on here, please feel free to go ahead and let us know where you are watching from. And as we go through our conversation today, feel free to go ahead and put questions in the chat, and we will get to them as we get towards the end of our time together. So Bryce, welcome to Psychedelic Nurses.
Thanks for having me on here. Very excited to finally chat with y'all.
Absolutely. I'm also doing a little bit of a one-man band here. We normally have somebody doing tech in the background, but we don't have that tonight. So if things get a little wonky, that's why you're seeing it live. It's live TV here. So Bryce, let's just, I know you and I know each other, but I'd love for folks in the audience to get to know you. Could you tell us a little bit about how you ended up in nursing? You know, I think nursing is one of these interesting professions where people end up in very different ways. What was your story?
I'll be honest, I kind of stumbled into it by accident. So when I was younger, kind of deciding what I wanted to do with my life, I was working as a lifeguard for many years. And my parents, like I gave a run at education after high school. I wanted to become an IT administrator, so I went to school to become a network administrator. And after my first semester, I got kicked out of my program for having 4 Fs and a D, and so I realized, maybe IT wasn't for me. And then at that time, my parents threatened to make me pay for rent if I didn't go back to school. So I opened the newspaper and found the first job that sounded interesting. And I saw there was a posting for like a paramedic training. So I was like, oh, I'm a lifeguard. I could probably do paramedics. That's fine. And so I did my training to become a paramedic. I loved it a lot. It was great. But because of some medical stuff in my background, I wasn't able to class up my driver's license to be able to drive an ambulance. So I finished all my training, finished all my practicum, and then was told I couldn't work as a paramedic for another 4 years. And so I was like, well, this is kind of annoying. I was like, well, I guess I'll find something to kill 4 years of time. And I'm like, oh, I'll check out nursing. And then did nursing and absolutely loved it. It was great. I am extremely happy to be a nurse. I'm very proud to be part of this profession, and I definitely feel like I'm a lot happier in this than I would ever have been in paramedics. So yeah, I kind of stumbled in it because I didn't want to pay for rent. So here I am.
A little bit of gentle pressure from the parents, right?
Yeah, very much so.
When I think I met you, a couple of years ago, you had a really interesting, it was a group setting, and you had an interesting introduction. You said something like, I prescribe heroin in my job.
Yeah.
Like ears kind of perked up, like, okay, this is different. So, well, maybe what we could do a little bit is for people who are less familiar with harm reduction as a strategy, to maybe talk a little bit about that. And then I would love for you to share what sort of specifically you do in that modality, because I know you do a lot.
Yeah, for sure. And so, harm reduction has some pretty long definitions, and I'll be honest, I'm always at the great at explaining the definitions, but I kind of take it as we take something that has some harms associated and well-known harms with it, and we try to reduce those harms without stopping that behavior. So some examples I kind of give for people is driving a car. When you drive a car, It's harmful. It's you're driving a death machine on the road, and we wear seatbelts, which would be a harm reduction technique. We don't splatter our brains on the pavement. And so you can take that sort of model and you can kind of expand it. And the part I normally focus on quite a lot is around like substance use harm reduction. A lot of substances do have some innate harms with them and also have a lot of benefits with them. So how can we minimize the harms and also maximize the benefits? And so when I was an RN, I worked with a public health group in Winnipeg, Manitoba, so in central Canada, as a harm reduction nurse. So what I was doing there, I was doing the wholesale distribution of harm reduction supplies. So sterile needles, cookers, and things to kind of break down drugs to be able to inject them or smoke them. In addition, I was working at bathhouses. So these are like areas where people can hook up and have anonymous sex at. And so I was working in those places doing STI testing. And around that time, I got brought on the board of directors with the Harm Reduction Nurses Association of Canada, which is a professional nursing association for nurses involved in harm reduction work. Highly recommend anyone involved in harm reduction, check us out. And then, so I was go with that. And then around that time, I decided to move over to Vancouver. I finished off my nurse practitioner training, and I did my final practicum at Insight. And so Insight is Canada's first sanctioned safe consumption site. So this is a place where people can bring their substances on site, cook it up and inject it or consume it in the presence of medical trained staff. So at that place, I was the safe supply nurse practitioner. So I was prescribing people pharmaceutical alternatives to the illicit drug supply. So in Canada, and I'm assuming and I know for most of the states as well, they're kind of experiencing a bit of a toxic drug supply, especially around opiates. A lot of the opiates are contaminated with fentanyl and there's other like potent opiate analogs in there as well. And we're also starting to see a lot more benzodiazepine contaminated opiates or benzo contaminated down. I think the numbers up here now is like 50% of the samples of down are coming back positive for benzos. So we're trying to help people reduce their reliance on the street supply. And so we would be prescribed, in my role at Insight, we were prescribing medications like Fentora, which is a fentanyl oral lozenge, sufentanil, which is an injectable form of fentanyl. We were also doing a bit of like hydromorphone safe supply, so Dilly 8s, so 8 milligram hydromorphone that we're prescribing people to help reduce their cravings and withdrawals, secondary to their opiate use. And these were prescribed to people not as a way to like get them completely off opiates, but as a way to help manage their cravings and withdrawal and be part of this whole continuum of opiate care. After I finished my clinical work at Insight, I got hired on with my current job at the Dr. Peter Center, working as the day health nurse practitioner, or also part of that role was the IOT nurse practitioner. So that stands for injectable opiate agonist therapy. So in some specific places in Canada, if you are not having success managing your opiate use with oral medications like methadone, Cadian, Amisulon, or Suboxone, and you're still very much attached to getting your drugs in your body via the injection route, you can get attached to an IOT clinic. And so I ran one of, I think it was like 3 or 4 here in Vancouver. So in that role, I was a legal heroin dealer. I was prescribing people diacetylmorphine, which is pharmaceutical heroin, to help people reduce their cravings and withdrawals from the illicit drug supply. And so the main one I was prescribing was the diacetylmorphine. That was kind of the main one there, but I was also prescribing injectable hydromorphone, the liquid version. We had probably about 95% of the patients wanted the diacetylmorphine, and maybe 5% like the hydromorphone. In addition to that, I do fentanyl patch for OAT. So out here in BC, and I believe some other places in Canada, we've kind of fentanyl patches has been shown as a new form of OAT. So long-acting opiate that helps manage cravings and withdrawal, especially overnight. So we're doing a lot of fentanyl patch prescribing, the Fentora, hydromorphone safe supply, oxycodone safe supply, the sufentanil, and then we're hoping to eventually trial some other products as well that are administered via intranasal route, because we have a lot of clients that don't actually like to inject, but would like to get opiates into their body some other way besides oral routes. So we're exploring potentially intranasal options for that clientele.
So a couple of terminology things. OAT, opiate agonist therapy.
Therapy, yes, correct.
Okay, and you used a term down, which I
Yes,
think I've not heard so much in the U.S. and maybe they may stop that one at the Canadian border. I don't know, but could you tell us what down is?
for sure. Historically, down usually meant heroin, like probably like 10, 15 years ago, it was heroin, but now it essentially means anything in a powder or rock that brings you down. So we're seeing a
Mm,
lot of interesting mixtures. So fentanyl is usually the backbone, but there's also nidazines. We've also had some xylazine contaminated down, benzo contaminated down. For a brief amount of time, there was some synthetic cannabinoids in down, and so
wow.
when I was working at Insight, we actually we did have some people who had full psychedelic experience, and while using their opiates, and we suspect it was probably because of some synthetic cannabinoid that was found in it, because some of the testing around that time showed that there was a small percentage of people who their opiates actually contained those synthetic cannabinoids in them.
Fascinating. I just find this whole thing fascinating. I mean, I've always, looked to Canada as having just sort of a practicality that you don't always find in the U.S. And so, I think most nurses in the U.S. are familiar with methadone and with buprenorphine as opiate agonist therapies, but it's actually, specifically written into our drug laws that you can't give an opiate other than those two to hold off withdrawal and to maintain, I think that the language is really arcane and kind of prejudicial, but to maintain an addiction or something is usually the term, I think the old terminology that was used. So what you're able to do there in Canada would actually be specifically prohibited, like to give people fentanyl, for example, or MS-Contin or something like that
Yeah.
for opioid, to prevent opioid withdrawals and to maintain and what you're really talking about too is another next level for the U.S., which is safe supply,
Yeah.
which we don't really have here.
Yeah, and it's like I think there was, to kind of step back a little bit, there was a couple policy briefs that kind of came around COVID time that allowed the expanded access for having a bit more freedom around managing opiate use disorder. And so that's around that time, that's when a lot of like the safe supply options sort of started popping up. A lot of the original protocols around safe supply were written for the context of helping people isolate during COVID. And they've kind of, now we're kind of just working on like evaluating that and seeing what the role of these sort of things. I
Mhm.
find it kind of weird that we draw, at least in Canada, there's sometimes like a line drawn between like this medication is OAT and this medication is safe supply. It really, like, it doesn't make a whole lot of sense to me. It's all underneath the umbrella of managing someone's opiate use disorder. And so,
Mhm.
like, there are some clinicians that treat the fentanyl patch as safe supply, and the original guiding documents are actually, they treat it as a safe supply option. But like, it's another opiate. It's just a long acting opiate that people can take to help manage their cravings. So I don't necessarily feel there's much difference between it all. It's opiates that someone can use to help manage their cravings and withdrawal, to help them manage their own what their health needs are and what they might actually need. And then also, what we can prescribe varies quite broadly from province to province. BC tends to be the most out there with what we can prescribe, but in there's most other provinces have a pretty decent expanded access. I know my original home province, Manitoba, NPs can't prescribe any Cadian independently. But out here in BC, where once you finish your training and show that you recognize you have like prior learning and all this, it's pretty open. The stuff with IOTs, like the injectable opiate agonist therapy, you need specific training for that one, but the restrictions on it are pretty small. It's essentially you have to finish a course and then do a 2-day preceptorship. And then as long as your clinic is set up to support that, you can do it. And that's the hard part, is getting like a clinic set up to support it,
Mhm.
because it is quite
Mhm.
intensive.
Yeah, and I got to see your clinic when I was up there visiting Vancouver this spring, and to see the site where you have the your injection room, which was quite pleasant, clinical but pleasant. It wasn't it didn't feel sterile, but it also didn't feel like it didn't feel shady in any way. It was brightly lit, and mirrors and safe supplies and that. And yeah, so I mean, the idea of having safe injection sites in the US still continues to be a fairly controversial idea. We've kind of flirted with this in San Francisco where I live, and a lot of times the pushback is you're enabling people to continue to use drugs, right? That are causing them harm. I mean, how do you kind of respond to that rhetoric? Because it's an election year. This is a hot topic.
Yeah.
We're having a significant overdose problem here in San Francisco and in the rest of the U.S. So how do you respond to that when people say you're just kind of enabling them
I
to
think all we're
continue to
doing
use
is
drugs?
I think all we're doing is we're enabling people to live and be healthy. Like people are going to a lot of times people are going to continue to use substances whether we give them a safe environment or not. And so we in my opinion, it's better to give someone a safe environment so that they can, we can respond to the overdose in a safe way if there is an overdose. It also gives us a great opportunity to connect with clients that we wouldn't normally encounter. And so a lot of my best conversations I have with my clients are in our safe injection room when the drugs are out on the table and everything. I've done some great health interventions from just like talking with a guy as he's like drawing up his down for the day and everything. So I think that sort of moment is very important, and I love it, and I love being able to access that. But at the same time, like that's like from a highly medicalized model of a safe consumption site, but we have safe consumption sites. They already exist. We call them bars, and so this is just a different form of safe consumption site. So I think all we're doing really here is enabling people to make great, like better decisions with their health and be able to be safer. I think people deserve that.
Yeah, yeah, I think about how a lot of times a bartender knows his regulars better than their therapist might.
Yep.
And that's in that safe consumption site, as you point out, that we have these for alcohol. They're called bars.
And like in a similar vein with like my IO guys and everything, like I spend so much time with them. Like I see them twice a day, every day. So I learn their tolerance. I learn what they get from opiates. I learn what they like from it, and it helps me better pick products for them that might work. So we can get this really sort of just like as a bartender would kind of learn your favorite drink and everything. It's like, okay, you like the pins and needles that you get from like diacetylmorphine. So, and because you're into old school heroin, so I think you'll stick on this one, or you don't really you're looking for more pain killing properties. So maybe this medication might be a better suit for you and everything, because it's not sort of like opiate use disorder is not a one size fit all. Everyone has different reasons for using opiates, and I think it's important to try to tease out what those are to be able to better support our clients.
Yeah, and it's an interesting point that you're with people twice a day, right? So you really are spending probably more time with them than just about anybody else in their lives, possibly.
Yeah,
Other
you
than
get to
maybe
see
who they
some
live with.
Yeah, and you get to see some wild winds and all that. I love hanging out with my guys in that room. It's a lot of fun. They tell me some pretty rad stories.
I bet. Yeah, I could really tell that you enjoyed the work that you were doing when I was up there, watching you in your clinic. So, I mean, this is just fascinating to me, especially living in the US where, our big progressive thing is we finally got rid of this thing called the X waiver. So you had to do additional training in order to prescribe buprenorphine for opiate use disorder. So when buprenorphine came out in the US, there was this thing called the X waiver, and the X waiver. So the X was an additional certification to your DEA license. So when you're a nurse practitioner or physician, you have this thing called the DEA license, which allows you to prescribe controlled substances to Schedule 2 through 5. So none of the Schedule 1 stuff. But you had, in order to do buprenorphine, you had to go through this additional, now get this, if you're a physician, you had to do an additional 8 hours of training. If you're a nurse practitioner, you had to do 24 hours of training.
Oh my gosh.
And having done the training, I can tell you there was nothing in the extra 16 hours that wasn't there in the first 8 hours. But in order to prescribe buprenorphine, you had to have this X waiver. So there was this big campaign the last few years to X the X waiver, and to allow, like you do in Canada, like they do in France, that anybody who can prescribe medication can prescribe buprenorphine. And so we've done that. But there's still this challenge in getting people to do it, because I think we've kind of scared people away from being able to prescribe it.
Oh yeah, I think a lot of that like kind of spills over up to us in Canada. Like I know before kind of understanding the whole system, like I was very worried about getting involved in substance use disorder prescribing, just because of like a lot of the flack that I hear coming from the States and everything. And it's sometimes hard to like piece out, is this like a Canadian issue or is this an American issue and all that? So it kind of spills over to us. And on the topic of like buprenorphine and like Suboxone, we do like home titrations now, where like you essentially give people like their whole titration dosages, and they essentially self-manage on their own. Give them an instruction manual, and I know there's a couple of ERs out here that just do it like it's a quick ER visit, and then you can leave in about less than an hour with a Suboxone script, if that's what you want.
Yeah, we've started. There's been more of that in recent years here, that sort of, especially post overdose, seeing that ER visit for an overdose as potentially a golden opportunity to start buprenorphine, right? Because people are going to leave, they're going to start withdrawing if they're not already, because they've probably been Narcaned, and they're going to use, right? So what if you use that opportunity to get people into treatment rather than to let them loose on their own, which is what we historically had done, or with a referral that they may or may not get to. So,
and I love those like moments when like people are susceptible or open to having more discussions around their opiate use. One of like the great opportunities I'm a part of is with Shambhala Music Festival. Is I actually run an OAT clinic out there. So we actually have a lot of people who come to the music festival who use opiates, who run out of their substance throughout the festival and are not feeling too hot. They're feeling like shit. And so we want to make sure they still have a good time at the festival, and we want to make sure that they can make it home in one piece and everything. So I've had in the last 2 years that I've ran the program, we've been able to start people on OAT medications and then hand them off to their home prescriber to continue that. So it's great. During that moment, they're receptive to starting OAT. So I want to be able to take advantage of that if I can.
Well, and you're striking on something that I think is really interesting. I think Carl Hart called this sort of psychedelic exceptionalism. That how I think of someplace like Shambhala, and I think about psychedelics, right? That's sort of the obvious association. Sort of like you wouldn't expect to find a lot of methadone at Burning Man. Is just but as you point out, that there probably is more of an overlap between these drugs like opiates and drugs like psychedelics in people that use drugs, that they're not necessarily siloed.
I find once you kind of start dabbling and stuff, no one really is a one substance person. Like in most of my experience working with things, most people have used multiple substances or use them for different reasons. And so it's very frequently I have people who are who use psychedelics, who also use opiates or use stimulants. And so, I don't really like that whole exceptionalism. I think it's perfectly fine to modify your psyche using substances in any which way you want. With LSD, someone might like LSD but not like mushrooms, and the same thing. It's someone might get a lot of benefits out of their opiate use but not off of their stimulant use and everything. So we're all just using them for different reasons, and I don't think there's anything innately bad about wanting to feel different or poke your receptors in a different way that makes you experience something. We have these receptors for a reason. So haven't we gotten to a point in our development that we can poke them more? Come on, why can't I poke these receptors but I can
right. We can poke our adenosine receptors every morning with Starbucks, but other things are off limits, right?
Exactly.
It's a cognitive liberty argument, right? That we can do these things if we're not harming other people. So I would love to hear more. You mentioned that you sometimes have these sort of moments with your guys in the injection room, and that you've also seen them happen sort of at at transformative festivals like Shambhala, and I think about, like, nurses. I think one of those sort of unspoken things that nurses often do, and that many people outside of nursing may not realize it, is we are there for those conversations, because we get to spend so much time with patients, and because they trust us, and because we cultivate this kind of relationship, that we're going to be we're more likely to be the person sitting at the bedside when somebody says, you know what, I got to stop drinking, or like, you know what, like, I'm 52. I didn't expect to have a heart attack right now. I got to do something different. Like, you're going to be the person who hears that. And so I would love to hear about that sort of intersection between like psychedelics work, because, people do have those like kind of epiphany moments after psychedelics, right? And it sounds like you hear something similar with your guys in the injection opiate, which is an intersection that I don't think I would have necessarily thought of until just now. So could you unpack that a little bit for us?
Sure. I think nurses like sort of bring the human to the medical system. It's very the medical system can be very like detaching, unloving, and very cold and calculated. And I think us nurses bring that human connection. We are humans. We have our issues, and I think we have our issues. We have our problems. We have our experiences, and I think it's good that we bring that to our care that we provide. And I know some nurses may disagree with me, but I think what makes me a good nurse is the things that I've experienced, and what I can bring that to my clients, and offer experience in that sort of way, and that sort of like lived experience that comes with it. And so when it comes to like these sort of like epiphany moments and nurses, I think yeah, because we do bring that humanity, we can better connect and meet our clients at the level. Like I find sometimes with other health professionals in there might be a bit more of a hierarchical relationship, and so it's sometimes hard to open up to those practitioners. And so, as a nurse, I try to, like, at least with all my with any time I do like health assessments for my clients, especially around like substance use disorder, I let my clients know, it's like, you know what, I have a history using substances, and I bring that to my work. So you be honest with me, and I'll be honest with you, and here we can try to meet in the middle here and try to find a way that works for both of us. And so, yeah, and I think when it comes to psychedelics, nurses are with people when they're born, and they're with them in their last moments. So why shouldn't nurses be with them at their most like spiritually or mentally significant time of their life, be that psychedelics? And so, I know nurses have a lot to give to psychedelics, and I love that we're in this field and working with them, because we're humans like everyone else.
I really appreciate that. One of the best compliments I ever got from a patient was like, Andrew, you're like a regular person.
Yep, it's a great comment. It's like, yeah, you know what? I'm not a computer. I am just a normal person.
I mean, what did Ram Dass say? We're all just walking each other home.
Yeah, exactly.
But I'm really interested in how you got to that place, because what I hear from a lot of people who are inquiring about open nurses or psychedelics and nursing is that, I mean, so nursing, my experience of it is that a lot of people are afraid of getting in trouble for something, right? I mean, we have these boards that tend to be rather punitive and rather black and white in their thinking. And, I think if you're working in harm reduction, or if you're working in psychedelics, you're more comfortable with gray areas. Like, you have to be, otherwise you wouldn't be here, right? And so, so that fear of getting in trouble, or, getting disciplined or something, is it's antithetical to what you're saying, which is like, you bring your whole self, like you self-disclose, and you kind of ask for that level of candor in return from your patients, but you demonstrate it before you ask from it. You're not asking them to do anything you wouldn't do yourself, is what I think I'm hearing.
Yeah, exactly.
And so, I think, how'd you get there?
It's like a lot of reflection. Like, I think part of me, like working and living authentically was very important to me. Like, I originally got into like my first professional nursing job was an emergency nurse, and I got really paternalistic during that time. Like, I was very judgy. Like, I was very judgmental to a lot of clients, and it was a colleague of mine who actually called me out on it. And I was like, actually, this is not how I want to, it's not how I want to be a nurse. This is not how I
Right.
want to show myself. And so when I moved over to my job in public health and in harm reduction, I essentially told myself, I want to live authentically. I want to be honest with myself. I want to be honest with my clients, within respectful boundaries and all that.
Sure.
And so I kind of, with some mentorship that really helped some great harm reduction advocates I knew back in Manitoba, helped me work through it. One of the position papers we put up with the Harm Reduction Nurses Association is around supporting nurses that use substances. So I was part of the team that kind of wrote that one up. And I think also, as an individual coming from a place of privilege, I think it's important to talk about like my experience with all these sort of things. And I think, we put a lot of pressure on harm reduction advocates and substance use advocates who have a lot to lose, and like, so do I. But like, I think it's, as someone who comes from a place of privilege, I think it's sort of my responsibility to try to open those up and have these conversations that people use substances, and people use substances more than just like alcohol or cannabis being legal up here and everything. And so and there is risk that's associated with that. And I think it worries me. It worries me quite a lot, but I think it feels like the right thing to do.
Yeah. I mean, I wonder if that paternalism that you spoke of is kind of in response to the amount of responsibility that we hold, and that I think, people that get in nursing are usually not kind of flaky around responsibility. Like, it's not,
Mhm.
if you don't want responsibility, nursing's probably not a good job for you. Right. And so I think most of us feel that weight of like, we're given a lot of responsibility, and, I know something I do sometimes in response to that is get very kind of serious, and that kind of paternalism like you're talking about. And,
Mhm.
but I love that you sort of talk about that journey of kind of moving through that,
Mhm.
into a place of like more authenticity, and just being who you are allows you to better connect with your clients. I mean,
Yeah.
that's really inspiring.
Thanks.
Well, I would love to. I'm sorry, you're about to say something.
Oh, I was just gonna say, like, it kind of like lends itself well to like some of the opiate use conversations we have with people. Like, a lot of times, like, we have talking to people who talk about like withdrawals and cravings, but I think something missing is around like the original reason people are using it, and that's like euphoria or pleasure
Right.
and that sort of stuff. And I think that is something that's missing from that. And I think it lends itself to being like more authentic around it. We're talking to, like, if I'm talking about different opiates, like, we want to talk about the different effects they all have and what you might get from them, and a
Yeah.
way to talk about authentically.
Right. I mean, maybe this is a way to sort of pivot into the psychedelic part of the conversation, but, I even saw that sort of like, yeah, I mean, there's such a deep vein of like Calvinism in healthcare of like, if it hurts, it must be good for you. Like, the medicine's going to taste bad because it's good for you. And if you suffer, if you hit rock bottom, that means, you're really going to change. Right. And if you actually enjoyed something, then it's suspect, right? And this came up, of course, with the FDA and the recent MDMA decision about this concern about, this being rewarding. And, I even heard, Michael Mithofer talk about this years ago, saying like he had some, had some subject in the study who said, got, with tears in his eyes, say something like, I don't know why they call this ecstasy. And it's almost like we had to message that, like, no, these don't feel good. You would never enjoy these. This is medicine. It's only, it's going to be hard.
Yeah.
Right. And that was like, made it a palatable message to the skeptical public. If it doesn't feel good, it must be all right.
Yeah,
But
which is
you're,
just
but
like,
you're saying it's okay to talk about that.
and I think it is, because it's just, that's part of the whole thing. And why can't euphoria be part of the conversation? Like, if you're having a euphoric response to it, aren't you more likely to take this or continue on this treatment? One of the examples is like, one of the safe supply options I use is like hydromorphone and oxycodone. And I find at the the pill concentration that I give people, the hydromorphone tab is about equivalent to the oxycodone, but I have better response from my clients with the oxycodone, and they tell me it's because they have a stronger euphoric aspect to it. And so they're using less of the street opiates, they're having less cravings, and they're having less withdrawal because they like the medication they're on.
You've built a better mousetrap.
Yeah. Yeah. Not so much like want to call it as a trap, but
Yeah, right. Sorry, poor choice of idiom there, but you've created something better there.
Yeah,
and safer because it's a known quantity.
Mm-hmm.
It's not coming in a baggie of unknown provenance. You know what it is that you're giving people, and they know what it is, and they can take a measured amount.
Yeah, exactly.
So, we are the organization of psychedelic and entheogenic nurses. So would love to also hear about your psychedelic work. And I just want to encourage the people who are watching this live to go ahead and put any questions that you have into the chat, and we'll get to those in the last little bit of our conversation here. But would love to hear, I know you do this harm reduction work. I know you do other kinds of psychedelic work. So would love to share any of that you'd like to.
Yeah, for sure. So I originally got into psychedelics, like psychedelic work from running my own harm reduction program back in Manitoba. So I was the director and founder of an organization called Project Safe Audience. We were supporting people at music festivals and raves who were taking substances, including psychedelics, with some crisis intervention and harm reduction work. And while doing that, we had people coming to talk to us under the influence of psychedelics. We were having these great conversations with them, and they would come back like later on in the festival, and they would be telling us, it's like, wow, that conversation really helped me out. It helped me figure some stuff out. I was like, that's wild. I'm like, I wonder if anyone else realizes that psychedelic can have medicinal benefits. And then I looked, and there's like a whole vast amount of research. So I was like, right. Okay, I'm like, this is something I can sink my teeth in. So I was doing that for a good couple of years, and then when I got my nurse practitioners, I got trained by TheraSil to provide psilocybin for end-of-life care. I think I was like in one of the first 2 cohorts in Canada. I was one of the first nurses to be able to receive that training to provide psilocybin for end-of-life care. And then I went and got the MDMA training, and I was in the first cohort for that. I wasn't the first NP. There's 3 of us that went through it, but I was in the first cohort to provide MDMA for PTSD through the SAP program in Canada, which is our sort of legal way of accessing psychedelics here in Canada.
Okay. Yeah. So how does one access psychedelics legally in Canada? Because we hear whispers about this south of the border here, but ever since you guys put that big wall up to keep us from coming in, like we can't find it. So
yeah, fair enough.
Tell us how that works up there.
Yeah, so there's a program, the SAP program, the Special Authority Program, is essentially petitioning Health Canada to provide medication that isn't formally approved in Canada for the treatment of conditions in sort of extreme situations. So the 2 obvious examples are treatment-resistant depression, and it was psilocybin for treatment-resistant depression and end-of-life care, and then there's also MDMA for PTSD. And so essentially you get a prescriber, either a NP or an MD, to submit the paperwork to Health Canada that says we've tried first, second, third line treatments. We're not showing any success. But we have this body of research from other countries that show that psilocybin or MDMA may be beneficial for the client. And we make our case to Health Canada. They review it, and if they approve it, they get us in contact with a approved lab in Canada, and they will send off the medication to the prescriber or a pharmacy that the prescriber is affiliated with. In addition, Vancouver has decriminalized certain substances, and so they decriminalized. I gotta update my knowledge on this because I know they changed it recently, so bear with me. But they decriminalized MDMA, opiates, and methamphetamine as part of a decriminalization out in Vancouver. And so some people were accessing it through that. So within nursing Canada, it's within our scope of practice to support someone while they use illicit substances. So I know some NPs where people were accessing street psychedelics and then using it in the presence of a healthcare provider or using it in the presence of a therapist. So they're accessing that way. But the main legal route is through this SAP program.
Okay.
Yeah.
So if I have PTSD that has not responded to conventional treatments, therapy and medication, I can petition, if I'm a Canadian citizen, I can petition the Canadian government, the health authority, the health ministry.
It would be the federal health, like Federal Health Canada.
So it's
So
a
like
federal level. It's not on
it's
a
a federal
provincial
level, yeah.
level. Okay.
No, yeah.
And I can say, I've tried all these things for PTSD. It's not working. I'd like permission. There's evidence that MDMA is effective for PTSD. I'd like permission to get that treatment.
Yes, yeah, that's pretty much how it works out.
Okay. And then because it's not approved up there in the same, in like an FDA approval would be here. So then I come and see you as a client and I say, Bryce, I want to get this treatment. I know you've been trained in this model. How do we actually connect the dots for me? I'm trying to figure out how do we get the MDMA, and then what sort of hoops do you have to jump through in order to do that?
Essentially, like there's certain groups that have like programs for assisting prescribers for navigating all this. Like if you're kind of coming into it cold without knowing how to submit the paperwork, it is a tedious process. Like you might be writing it up for like 4 hours, but the program I work with, they're still they sort of get clients that come to them looking for compassionate access to psychedelics. They were the original, like they're essentially suing Health Canada right now for more access to psychedelics for compassionate reasons. And so the clients will come to that place. They will fill out some paperwork, and then they essentially send that paperwork off to me, where I meet with the client, chat with them, figure out what their goals are, what their other health conditions they might have, do sort of a health assessment, and then finish out the rest of the SAP paperwork, which is about like 10 pages or so. And majority of it is just like quoting research articles and showing that other treatments are inaccessible, like ECT or what's that, transcutaneous membrane stimulation. Essentially, you have to show that like other treatments won't work with this client, or they've been trying, they haven't worked in the past. And then so at that point we submit it and send it off to Health Canada. They can take as long as they want to kind of get back to us, and then essentially they will connect us with a lab that the client will have to purchase the MDMA from, and it's a bit of an exorbitant price for it compared to street cost. And then then essentially I hold on to it until I can meet with the client and administer it. The one thing with the SAP though is essentially all the responsibility for outcomes falls on the prescriber, because it isn't fully approved yet in Canada. So instead of, falling back on like kind of informed consent sort of stuff, it falls on the prescriber. So, if there's a negative outcome, it's my responsibility it's already my responsibility, but it's more heavily focused on the prescriber. And like, why did you think this unapproved medication would work on this client? Clearly, like there's having this negative outcome now and everything.
Okay.
So it does put a lot of stress on providers.
Yeah, and I don't know enough about the sort of Canadian malpractice landscape, but one of the things that keeps people apprehensive in this country, at least, in addition to our sometimes capricious and punitive licensing boards, is the fear of getting sued for malpractice. And so the obvious argument, I don't know, I mean, let's run a worst case scenario. So I come for this treatment, I have MDMA, and I flip into AFib, because it's a stimulant, right? And I could have some cardiac complication, and I get really upset about this because now I'm, having to deal with that. And can I sue you for malpractice at that point? Like, are you vulnerable at that point?
Essentially, like you would do your due diligence to rectify that. So like calling emergency services. I have medications on hand to deal with any of those things. There is, anyone can kind of sue anyone for anyone, but it would essentially be on me to show that we did everything in our power to make sure that this was safe and responsible for the client, more so than we would sort of encounter in medications that are already approved for use.
Okay, so sort of, since you don't have the sort of a drug label to kind of fall back on and say, well, we followed the label and we did our due diligence per the label. It's kind of more like what is known about how to use that drug safely. Okay. Oh, that's so fascinating.
Yeah.
Yeah. I mean, you have to understand what a fascinating perspective Canada has, for somebody living in the US with our weird draconian drug laws. And like, I mean, I think my first trip to Canada was like 30 years ago, and I was in Vancouver actually, and I was listening to CBC, and it was, during the rave, warehouse rave parties. This is in the 90s, right? And, they were talking about these kids that were throwing these raves, and they were getting these complaints, but the local authorities are working with them to find a better venue. And I thought, in the US, they'd come in, the cops would come in and shut the whole thing down and lock it up. But, in Canada, it's like, let's find a reasonable solution. I thought, wow, that's a totally different way of looking at these things than here.
Yeah, exactly. And like I think like an example too is like even with that Shambhala Music Festival, like it's been operating for 25 years at this point. Everyone knows what's going on there. We have full on drug checking services. We they have like 5 or 6 FTIRs, which are the drug testing machines, running like 20 hours a day. So like everyone knows that's what's kind of going on in there. But the police sort of like they get in because it's private property. The police can get invited in, but essentially they're just sort of just saying it's like, okay, yeah, you guys are still doing this. You're not having any issues. We'll see you next year.
Wow.
Yeah.
So just the technical aspect of that, you were saying, so like I can come to that festival with a baggie of mysterious white powder and say, can you tell me what this is?
Yes.
And
Yeah.
you can run it through gas chromatography.
Not gas. Like depends on the year. They have different technologies on site. The bread and butter one's the FTIR, which does have some limitations. But that's sort of the bread and butter for all that. There have been thin layer chromatography on site before. I think they had gas chromatography as well. I can't remember off the top of my head, but they always definitely have those FTIRs. But really, anywhere in Canada, you can ship your drugs to a lab and get it tested. Like I know you all have like pill reports and like down in the States and all that, but we have like getyourdrugstested.com. You can just ship your drugs to them, and it's a venue in Vancouver, and they will just test it for you and send your results back in a couple weeks or so.
Wow, amazing. And at the festival site, how long does it take to turn around a result?
Honestly, the longest time is waiting in line. But once you get on there, it's like a minute. It's like a minute and a half. But you could wait in line for quite some time. And like people use the testing services, and it's actually showed quite a lot of positive results. So they do analysis on the drugs that they're getting back and the rates of contamination. And what they show, like since starting doing drug checking, the drugs have been getting more or less and less contaminated as the years go by. Like it's showing that people aren't bringing contaminated drugs in there because you're not going to be able to sell them. You're not going to be able to. People don't want that. People want. And so what the data is showing that drugs that you bring to the festival are probably less pure than the ones that you can acquire on the festival grounds.
I mean, it's kind. I know it's kind of a fashionable thing to bash on free markets, but you got to appreciate the free market forces in that like, hey, if you're going to sell a product to a market, it can't, and they're going to know what's in it. It can't be crap.
Yep.
Right. You actually have to like put some effort into making it what you say it is and reasonably safe.
Yeah. That being said, like there's still some stuff that always kind of makes me chuckle coming through. Like I think some guy was selling Pop Rocks as MDMA at one point.
You mean the candy?
Yeah, the candy. Yeah. What else? There was someone got their ashes tested. So essentially someone had found an ampule of something on the dance floor and thought it was drugs, brought it to the drug testing center and found out it was ashes. And so probably an awkward conversation.
Well, I'm glad you didn't snort grandma.
Yeah, exactly. Yeah.
Yeah. Well, things you see at medical tents at festivals, right?
Yep, very much so.
And then like I know like ecstasydata.org in the US does do testing. Mm-hmm. Now there's weird rules that they have to follow. Like they are not allowed to they can't quantify, if I'm remembering this right, they cannot quantify the exact number of milligrams in a given sample, but they can put ratios. So they can say this pill that has a Superman logo on it that weighed 300 milligrams is 6 parts MDMA, 2 parts, caffeine, and 1 part Benadryl or something, they can say that. And then they will post pictures of that, pill along with where it was sent in from. So you can be like, hey, I have a pill that looks like Superman. Maybe that's the same one. But so do they publicize their findings?
Not right. So to break it down that much, like one of the limitations of the FTIR is it can't really accurately tell you the percent. It can vary quite wildly. And then okay, let me see if I can get this right here. If a sample, if there is more than, it can't tell anything that is less than 5% of the total weight, but you can have multiple 5% up to about 50%. Right. So if you have a sample that is contaminated with like 10 to 15 different things, in theory, 50% of it won't be detectable because of that FTIR. If it lies within that 5% range, if that kind of makes sense. So there are some places that do give out percentages on the FTIR, and I always caution people to like take it with a grain of salt. A really good technician might be able to who understands the drug landscape, might be able to give some good indication of like maybe maybe a little bit of the percentage. But there are some places that give out like hard percentages, and all they're using is the FTIR, and those can vary quite wildly. And even because FTIR is like a non-destructive testing method, you're only testing that small bit. And then even with like the more destructive testing methods that give you a more accurate one, like you destroy the sample and you got the whole percentage, but now you don't have the sample anymore. Like you don't have the thing that you tested there for. So like, yeah, drug checking is great. I think it's a bit of a stopgap. I think we need like legalization and like control for these sort of things, because this doesn't solve all the issues that comes with a toxic drug supply. It's a great way to give harm reduction information, a great way to get the conversation going about knowing what's in your substances, your intention for use, and all that. But it has its limitations.
Yeah. So a safe supply scenario in that would be that you could buy your MDMA or your LSD at the festival.
Yep, and that's like the testing results are showing that the substances are getting more and more pure every year.
Right. Which sounds radical until you realize that like most festivals have beer stands.
Yep.
Right.
That's why can't we have like a psychedelic stand? Why can't I go buy some 2CB at a music festival? Like we have a container there, we have medical sites on sites and everything. What I submitted for my master's program for like my capstone project was around supporting people using psychedelics in non-medical settings for like medicinal benefits. So essentially supporting people at raves and music festivals who want therapeutic benefits from psychedelics, but don't want a intense therapeutic relationship with like 2 therapists and all that sort of stuff. And so we were doing like intention setting with clients from sort of a harm reduction standpoint, like talking about dosaging, what your intention was going into it. And then they would take the psychedelic at the music festival, and then we would have like integration circles after, where we kind of go over what people learned and everything. And people were getting benefits from it. And like, and I don't think everyone needs that sort of intensive management that is sort of the current model with psychedelic therapy. I think, why shouldn't you be allowed to go like buy a bunch of acid at a music festival and have a good time? Like alcohol is way worse for you. So
yeah, it goes back to that whole question about, why are we so apprehensive about pleasure? Might pleasure be therapeutic? I mean, it's the inability to experience pleasure is one of the symptoms of depression, and we call it anhedonia, right? And most of our treatments, pharmaceutical treatments, aren't very good at treating anhedonia. It's probably the most resistant thing to treating in depression with conventional medications. But ketamine and psychedelics seem to move the needle on it, which is provocative, right? So man, we could talk all night. But I mean, I'm just so impressed with like, Wendy always likes to say, nurses are the Swiss Army knife of psychedelics. And I'm expanding that to think that nurses are really the Swiss Army knife of healthcare, and I think you are a great example of that. There's a few questions coming in here that I want to, one's a technical one. So let me just pop that onto the screen here. And the other is probably a good place to wrap up with. So with this example around, that I gave around AFib, like, would it be due diligence to do a full cardiac workup with an EKG if you were going to do an MDMA session with somebody through that access program that you described through the government?
I think like there is some like exclusion criteria within it around like hypertension and all that. So I essentially do have a conversation with the client being like, have you encountered any cardiac symptoms? Do sort of a review of system of any cardiac sort of stuff. I get a blood pressure from all my clients, but if there is no family history or any sort of things that would lead me to believe that they are at risk for it, I haven't done an EKG for those sort of things.
Okay.
And I think like even with like my experience working at Shambhala, like, and that's I will be honest, it's a very young population, and take this all with a grain of salt. I'm not offering medical advice here, but with that very young population, we don't really see that too many cardiac changes that happen, like besides tachycardia. But like, yeah, I can't even think of once where we've had someone end up in AFib secondary to just MDMA. You throw some cocaine in there or some other stuff in there maybe, but yeah. And so I think it's prudent to do your due diligence and see, like, get to a point that you feel comfortable that your clients will have a good outcome from this, and that you've checked off all the bases with that. But yeah, I don't think, if you don't have any sort of reason to believe that the client has any sort of underlying arrhythmia, I don't see why you need an EKG for everyone.
So it sounds like, as you're using the published evidence of that on that drug and that condition to justify the approval from the government, you're also looking to the way the studies were conducted. So like, I am often the medical monitor for our studies in our lab. And so, we do get an EKG for everyone because the FDA, as we found out from this recent situation with the FDA and MDMA, if you don't have all that data in place, the FDA is going to ask you about it, right? They're going to say, how do you know that this doesn't cause cardiac events if you didn't monitor for it? Or it was more with the FDA, with MDMA, it was more around liver stuff because we didn't have the pre and post. But so what I'm hearing there is like, you're kind of looking to the screening requirements for those studies to guide you in what you look for with a potential patient.
Yeah.
Okay. So here's the less technical, more 30,000 foot view, but I think this is a beautiful question from Dominique, who's just next door in Calgary, just down the road, right? What are the biggest hurdles you've come across in your journey to all the cool things that you do? And they are really cool. Did any of it almost break your spirit? And how did you cope with the pushback?
Yeah. So I can tell a bit of a recent story and all that. So things are kind of changing here in BC around substance use management, and I encountered a couple pretty rough things that kind of happened around getting approval for certain medications, and not being able to provide care that I think is needed to my clients. And I'll be honest, it fucking sucked. Like, it was pretty brutal. And so what I kind of did was sort of take a little bit step back and recollect myself a little bit and try to, realize why I'm doing this work, why this work is important, and kind of lean on some mentors to kind of help support me through it. Because it sucks to get to like be running forward and then come up against hurdles that you don't really have a solution to get by. In my other sort of work with like within psychedelics, I found most of the time you can find creative solutions to get around anything. It might take some time, but I try not to like lose hope. I try not to get too bogged down with all that, because if I do, it kind of I get really bogged down with it. I have ADHD, and so I have like a motor running in the background at all times and everything. So I find, like, for me, I just kind of keep pushing forward, and it really helps. but it definitely has led to like burnouts. Like I have some burnout around managing substance use disorder, so I am taking a little bit of a break in the next little bit. Um, and I think that's important. I think it's important to know when you've reached your limits and kind of hand off the torch to someone else and until you're ready to take it back on. Because we're not supposed to be martyrs here, though many of us sort of end up that way. Yeah.
No, I appreciate that on a number of different levels. I mean, obviously as a fellow nurse, that that is one of the blessings of a profession, is that we can do lots of different things. And so if something gets tiresome or you're just not feeling it, then we can pivot, right?
Mhm.
But I also, I feel like there's also been, since the FDA decision, a little bit of a demoralization. People have been feeling kind of discouraged and like, when is this ever going to happen? And like, what I'm hearing from you is really kind of taking the long view, and also saying it's okay to take breaks in there too. Like,
Yeah.
this is a marathon, not a sprint.
Yeah.
And it's okay to pace yourself.
And it also opens up for like creative ways of working around things. Like I think I don't have a great understanding of how it works down there, but I think the ideas around like psychedelic churches is wild. I think that's
Yeah.
a very interesting way of being creative in solutions and everything. So when a door closes, like take a break, but where else? How can we else approach this? How else can we move around this and try to find a different way to approach this?
Yeah.
Yeah.
Yeah, and I appreciate that too, because it feels like with the FDA decision, there was this great hope of sort of doing this through medicalization. But even within the psychedelic community, it seemed like you know that as we got closer to that goal, there was more apprehension, right? If signing on with a medical model meant that certain people weren't going to be able to provide this, or certain people weren't going to be
Mhm.
able to obtain to acquire it, or get treatment, or it was going to be exorbitantly expensive, and so it seems like in that sort of wake of that discouraging setback, there's been this like, well, we'll just go back to the underground, and I mean, there's certainly plenty of things that, plenty of values in the underground, but what I'm hearing you say is that maybe we think about a third way, that
Yeah.
maybe isn't medical, but maybe isn't totally unregulated. Um, and maybe there's other models that we haven't even considered yet,
Yeah.
you know?
I think there's a really good paper I read a while ago. Mark Hayden wrote it around models for psychedelic legalization or decriminalization or access,
Uh,
and I really liked the options there. It was like around like you would essentially get a like certificate to essentially it's like training to take psychedelics for yourself personally, and you
huh,
could do that and support that. And then there was like an additional licensure, which would be more of like a medical model one, where it's like you can administer psychedelics for therapeutic purposes, and it's not so much medicinal, but like also like spiritual workers would be able to be a part of it. Other individuals who have invested interest in psychedelics who might offer some benefits from their sort of framework would be able to offer psychedelics. Because I 100% don't think psychedelics should live in a medical model. I think
yeah,
we won't do it justice in a medical model. And so I would love to see there to be like a professional psychedelic association that regulates psychedelic practitioners, and be able to um, work with it in different ways. Because like I always, yeah, like I myself personally, I don't get much spirituality from any psychedelics, but I know lots of people do, and so I think there should be people that can support people from that spiritual side as well to be
uh-huh,
able to use psychedelics. And so, yeah.
yeah. Bryce, we are up against the clock here, and I want to just ask you one last question. We get a lot of people who are earlier in career than you and I are, or maybe even just considering a career in nursing. And we always love to end these interviews by asking, if you could go back and give your younger self a piece of advice, because clearly you've done have done and are doing some really amazing things. What advice would you give your younger self?
Um, Honestly, like just follow your heart. Like follow what drives you. Figure out what inside you makes you tick and makes you want to keep moving forward, makes you feel excited inside. Because then like you're always going to feel that drive to keep moving forward and being the best that you can be in whatever chosen field. I'll be honest, I'm pretty happy about the decisions I made in my life. I think just yeah, I think it's just good advice for people. Just find out what makes yourself tick and what brings you joy, and do that. That's what you should do.
Well, your example is an inspiration, and really appreciate you taking the time to be here tonight. I know a lot of people I know a lot of people have been watching as we've been talking, but many more will watch on and to anybody who's watching this for the first time tonight, we have an increasing library. We're now up to maybe 35 of these interviews over the last few years that we've really been able to find, leaders like Bryce to share their wisdom with us, and we encourage you to check out those archives because they're important learning, and I also think they're an important part of this history that we're living in right now. And so thanks for being part of that. We will be back next month. So please keep an eye on your email boxes and the social media channels. We're on Facebook, of course, for announcements on the next interview. And Bryce, thank you again for taking the time with us tonight.
Awesome.
All right,
Thanks
everyone.
very much for having me.
Yeah. Good night, all.